A 34-year-old Caucasian male presented with a dry cough and progressive shortness of breath for 3 months. I am showing you his initial chest radiograph. Describe the findings.
Okay, assessing the provided imaging. The chest radiograph demonstrates bilateral reticulonodular shadowing that predominantly affects the mid and upper zones, with relative sparing of the absolute apices. The nodules are small, measuring approximately 3 to 4 millimeters, appear ill-defined, and coalesce centrally to form confluent airspace opacities. Additionally, we can see bilateral hilar enlargement, which is more pronounced on the right, and widening of the right paratracheal stripe, consistent with mediastinal and hilar lymphadenopathy.
Excellent. What is your primary diagnosis?
So, given the combination of symmetrical bilateral hilar and mediastinal lymphadenopathy with mid to upper zone reticulonodular changes, the primary diagnosis is pulmonary sarcoidosis.
What are the key differentials for this pattern of bilateral hilar lymphadenopathy?
If we look closely, the main differentials for bilateral hilar enlargement include sarcoidosis, lymphoma, and tuberculosis. If we see eggshell calcification of the hilar node specifically, we must consider sarcoidosis, silicosis, and post-radiotherapy lymphoma. For perilymphatic nodules, we also include lymphangitis carcinomatosa and Kohlwerker's pneumoconiosis.
What is the typical demographic and systemic manifestation of sarcoidosis?
Sarcoidosis typically affects young adults, with a peak incidence in the 3rd to 5th decades. It is more prevalent in women and Black populations. It is a multi-system disorder characterized by non-caseating granulomas. Extrapulmonary manifestations include uveitis, bilateral parotid enlargement, erythema nodosum, lupus pernio, arthralgia, cardiomyopathy, heart block, and bony changes in the phalanges.
Eggshell node calcification is a well-known feature of sarcoidosis. Let's look at this chest radiograph 1B. Describe the calcification shown here.
As seen in this chest radiograph, which shows bilateral hilar enlargement with hilar lymph node eggshell calcification, the calcification presents as a thin, dense ring of calcification along the periphery of the hilar lymph nodes. It occurs in approximately 5% of patients with sarcoidosis.
Now look at this axial CT image 1C. How would you describe the lymphadenopathy shown here?
All right, as seen in this axial CT image, which demonstrates bilateral hilar lymphadenopathy, we can appreciate prominent symmetrical perihilar lymphadenopathy without any associated pulmonary parenchymal disease.
Let's evaluate the parenchymal detail. Describe the findings shown on this HRCT scan.
As seen in this HRCT axial image, which demonstrates multiple nodules distributed along the bronchovascular bundles and subpleural regions with nodular thickening of the interlobular septum, we can appreciate that the tiny pulmonary nodules are distributed in a classic perilymphatic pattern. They are located along the bronchovascular bundles, the interlobular septa, and the subpleural regions, with nodular thickening of the interlobular septa and the pleura, which is often most prominent along the interlobar fissures.
How are chest radiograph changes classified in pulmonary sarcoidosis?
Based on that, they are classified into stages 0 to 4. Stage 0 is a normal radiograph. Stage 1 shows lymphadenopathy only. Stage 2 demonstrates both lymphadenopathy and pulmonary infiltrates. Stage 3 is characterized by pulmonary changes without lymphadenopathy, and Stage 4 represents end-stage pulmonary fibrosis.
Although gallium scanning is rarely used now, what classic signs are associated with sarcoidosis on this modality, and how would you manage this patient?
I'd say 2 classic signs on gallium scans are the lambda sign, showing symmetrical paratracheal and bilateral hilar uptake, and the panda sign, showing uptake in the parotid, salivary, and lacrimal glands. For diagnostic support, elevated serum angiotensin-converting enzyme, or SACE levels, can be measured. I would refer the patient to the respiratory team for a multidisciplinary approach, including pulmonary function tests and biopsy to confirm non-caseating granulomas. From a radiologist perspective, comparison with previous chest radiographs and further cross-sectional imaging with HRCT would be key.